Hello, everyone. My name is Lori Strauss, and I am the LGBTQ plus and people with disabilities audience strategy manager at AARP. My pronouns are she and her, and I'm a 6 foot tall white woman with white gray hair, kind of long. I wear purple glasses, and I use hearing aids. We are so pleased to be sponsoring today's discussion with the Outwards Archives because we know how important health and healthcare are in the LGBTQ plus community. AARP's research team recently released a new report in our Dignity series that captures how LGBTQ plus adults over 50 think about their health and the health of those they care about. You can read the full report using the QR code that was just on the screen or by using the link that Jack is going to put in the chat. Now, without further ado, I want to turn the conversation over to Jack McCarthy of Outwards Archives. Jack, take it away.
Hello and welcome. Thank you so much, Lori. My name is Jack McCarthy. A visual introduction is that I am a white transmasculine person with a dark sort of faux hawk and a flowered shirt with a blurred background. I'm joining you from Los Angeles, California, on the traditional, ancestral, and stolen lands of the Tongva peoples. As a guest institution on Tongva land, Outwards makes Kui Nawa a recurring guest exchange to the Tongva Tarahat Pahava Conservancy, the Tongva-led organization who received the first return of land back to the Tongva people. If you'd like to learn more about how to pay a voluntary land tax to the indigenous peoples in your own area, I just put a link about how to do that in the chat. If you'd like to see closed captions for today's webinar, you can click the CC button at the bottom of your screen, and that says show captions. Please feel free to ask questions for our panelists in the chat or the Q&A function throughout today's panel. I'll be the one monitoring that. And if you have any tech issues today, I am also your behind the scenes tech wizard, so please feel free to reach out to me in the chat if you need assistance. As mentioned, I am the communications director of the Outwards Archive. Outwards captures, preserves, and shares the stories of LGBTQ plus elders to build community and catalyze social change. We were founded 8 years ago, and in that time, we've conducted nearly 350 interviews in 45 states plus Washington, D.C., hoping to get to all 50 this fiscal year. And it is always an honor to partner with AARP for these special events. It is so exciting to get to uplift the work that AARP is doing around health equity. And now I'd like to introduce our host for this panel, Dr. Jesse Ehrenfeld. Jesse M. Ehrenfeld, MD, MPH, is the immediate past president of the American Medical Association. He is a senior associate dean, tenured professor of anesthesiology, and director of the Advancing a Healthier Wisconsin Endowment at the Medical College of Wisconsin. Dr. Ehrenfeld made AMA history as the first openly gay president of the organization. For the past 2 decades, he has been a nationally recognized advocate for LGBTQ plus individuals. In 2018, in recognition of his outstanding research contributions, he received the inaugural Sexual and Gender Minority Research Investigator Award from the director of the NIH. So welcome, Dr. Ehrenfeld.
Thank you so much, Jack, for that very kind introduction, a visual introduction. My name is Jesse Ehrenfeld. I am 6'3", Caucasian. I'm wearing a suit and a bright pink tie for today's webinar. And I just got a shiny new military style haircut because I spent 10 years in the Navy, and it's what feels right for me. I want to just take a moment to thank AARP and Outwards for hosting this panel, and not just for the conversation today, but really for all of the work that you're doing to shine a light on the health challenges faced by LGBTQ plus seniors. This work is so vital and so important because for all the progress that we've made in securing LGBTQ rights over the decades, it does feel at times like we're still fighting against a current wave of bias and discrimination, especially in healthcare. So the American Medical Association is committed to addressing the longstanding inequities that LGBTQ plus patients and other historically marginalized groups encounter too often when interacting with the healthcare system. And this is true for children, it's true for young adults, and it's certainly true for our senior patient population. We're working hard to educate physicians and medical students on the issues, as well as the unique health needs of LGBTQ patients. We're fighting against efforts across many states that seek to restrict the kind of care patients can receive. We believe in the sanctity of the patient-physician relationship, and that fundamentally, patients, seniors, all of you have the right to make your own decisions about your healthcare and your care needs. But as the AARP's recently released Dignity Report shows, there are still glaring areas of need for our seniors who are LGBTQ plus identified when they're trying to interact with the healthcare system. Too many obstacles. So we've got to focus our attention on these gaps. We've got to work in partnership with other organizations to ensure that seniors have access to the care that they need when they need it. Among the concerns for senior LGBTQ patients is social isolation and a persistent challenge to ensure that they have social supports that they need as they age. Of course, the health challenges of this patient population are occurring across the broader backdrop of physician and healthcare worker shortages for all patients and in all corners of the country. Today, as we're talking, it's estimated that more than 83 million people in the US currently live in an area without sufficient access to a primary care physician. Millions more lack access to specialists like cardiologists, radiologists, my own specialty, anesthesiologists. The AMA is deeply concerned about access to care issues, and we know that for LGBTQ plus individuals, this can lead to devastating consequences. We know that LGBTQ people experience unique health disparities. Having access to a primary care physician can be the difference between accessing PrEP or treatment for HIV/AIDS, getting support for behavioral health challenges, or simply getting the routine care that they need to live a healthy life. So, as we think about the type of care that LGBTQ plus seniors receive, you've got to remember that many patients who are 50 plus have lived a lifetime of legal discrimination. So we've got to continue to focus on how to deliver compassionate, comprehensive care and ensure that physicians understand the unique needs of this community. We're doing that a whole bunch of ways at the AMA. We've partnered with SAGE, the country's largest organization dedicated to improving lives for LGBTQ older adults, to provide resources specifically designed for physicians to understand how do you create an affirming healthcare space for LGBTQ seniors. And more broadly, we're focused on expanding services for telehealth to ensure that everybody can get access to a physician's care when they need it. We're working hard to fix our broken Medicare payment system, which is forcing physicians all over the country to reduce their hours or stop seeing Medicare patients entirely, further threatening access to care for seniors. And we're continuing to push back against the growing interference in medicine from those who seek to criminalize necessary care and take healthcare decisions out of the hands of doctors and patients. We look at all these issues with a clear mission. Everybody deserves access to high quality, evidence-based healthcare. Everybody, including our LGBTQ seniors, have the best chance to thrive when they're supported and can get the healthcare that they need, free from discrimination, unconscious bias, or stigma. So I'm really looking forward to this discussion on how we can create a more inclusive healthcare system, address disparities, and ensure greater access to quality and compassionate care. So with that as a starting point, I am so excited to introduce you to our panelists, Earline Budd and Cassandra Burton. HIV and trans health advocate Earline Budd is the founder of Transgender Health Empowerment and a recipient of the Community Builder Award from the Advocates for Trans Equality. She lives in Washington, D.C., where she served as a transgender coordinator at the HIV Community Coalition and a commissioner for the D.C. Human Rights Commission. Cassandra Burton is a senior research advisor at AARP and author of the LGBTQ-focused Dignity series of reports. Cassandra also leads the LGBTQ plus research work at AARP and is chair of the LGBTQ plus employee resource group. She also teaches undergraduate courses in gerontology, sociology, and diversity in aging. Our other panelist, unfortunately, Rupert Kinnard, couldn't join us today. So we're going to go ahead and meet Arlene and Rupert through this short video, and then we'll meet Arlene in person.
As I got into my teens, I started hearing about AARP, AIDS-related complex, and I think it was in my 20s, I started losing friends. My friends started dying, and it was like, wow, I was crazy. I said, what is going on? Why are people dying like this? Because I was on the street, I had started doing survival sex work. There was a group of guys, Alexander Robinson, Jonathan Kirkland, and a few others. They were doing outreach to folks in the community that were doing commercial sex work, specifically transgender. They recruited me and several other transgenders and some gay guys to be in the program. It was the Inner City AIDS Network program. They were funded by the DC Department of Health. And oh my God, those guys were just everything to me. They took us through what was like a 5 to 6 week certification course on becoming a HIV peer specialist. That was my first experience with understanding HIV, understanding also that I was part of a community that was heavily impacted at that time by HIV.
I was really in uncharted waters being in the hospital, because I had never been in a hospital. I had never had a broken bone. I had never had anything ever happen that would lead me to stay in a hospital. I had on a back brace. And I think I knew that Scott was on his way. He basically came in and said, I'm Scott Stapley, I'm Rupert's partner. He looked around and said, you have to get a cot because I'll be sleeping with him, next to him. It was life-saving that he was there, because the staff, it was such a badly trained staff. And Scott basically would say, okay, he really needs to be tended to here. And I just remember being in awe of it. And I really understood what it meant to have a health ally, someone advocating for you, because he did it every step of the way.
Well, Earline, Cassandra, it is so great to have you with us today for this conversation. Earline, let me start with you. We just heard a bit of your story in that video, but could you tell us a little bit more about yourself and your experience with our healthcare system?
Thank you. Again, I'm Earline Budd, and it's been a bitter, long road struggle. I am 66 years old. And as you can see, I'm a transgender woman and of color. And I've been doing this work for over 30 years. And I think that video I didn't know anybody had archived that. And it touched my heart in such a way to focus and go back to reminding me of how I got where I am today as a senior LGBT individual in the community. And, I do this work not because of accolades or for any type of gratification. And it's just, my life has been saluted in so many ways. I have a mirror on H Street, which normally you don't get until you die. And they've given me that, a picture photo mirror on a big wall. And I'm here at HIPS. As you can see, my t-shirt says HIPS, and this is where I work. I'm the program manager for reentry for LBGT and others. And we carry a caseload of about 100 people. And of those, believe it or not, a third are seniors that are LBGT individuals. And all I can tell you is that there's not a day that goes by that we don't find an emergency situation or case. But, you know, there's always the housing issues, there's substance abuse, there's mental health, and just so many other things that I could talk about in terms of what we call family estrangement and the social isolation, all of that just compounds. And so we are trained to be able to address people according to how they're presenting, and harm reduction is what HIPS is about here. So we're reaching people where they're at, but I can tell you sometimes it just gets so hard. It really gets hard doing this work. And I know you're not supposed to take it home with you and all of that. We're trained. But sometimes I go home and all I can think about is, what am I going to do to help this individual or that? And I just can't, I can't. And that's from my personal experience of being a survival sex worker, being on the street, being homeless. And yes, now I own a home. You know, I'm doing well, but I just feel like I want to do so much more for my community. So thank you for allowing me to share that bit of information.
Well, Earline, thank you for everything you have and continue to do for the community, and for sharing so many of the personal details of your own experience, which obviously informs your work each and every day. That's so important. Cassandra, maybe you could speak a little bit more about the AARP 2024 Dignity Report for LGBTQ plus seniors, and let our audience know kind of what it's all about if they haven't seen it.
Sure. Thank you so much. And so happy to be here as well. So I'm Cassandra Burton. Pronouns are she and her. Wearing I don't even know what color blue this is, but a bluish gray button-down shirt. I'm African-American and I wear glasses. So AARP has been doing research on LGBTQ older adults 45 plus since about 2017. This is our fourth iteration called Dignity 2024. And our goal was for every new study to introduce a new issue that we thought would be important to the community. And for Dignity 2024, we want to focus on healthcare experiences, challenges, and some of these inequalities. And we purposely oversample to make sure that we are inclusive. And so we oversample African-American, Black, Hispanic, Latino, Asian Pacific Islander, transgender, and non-binary individuals to really get a more complete picture. And again, I'm so excited about this work because we have like some high points in terms of, you know, people say, our respondents say, you know, they have access to healthcare in their communities, but they also say, I have challenges, and those challenges kind of range the gamut. And I know that we'll talk a little bit more about this, you know, as we continue on in the conversation.
Well, I want to encourage people to take a look at the report if they haven't already seen it. There's a link in the chat. It's really eye-opening on a couple of levels. One, just to catalog what's happening across the country today for our LGBTQ seniors, but also to not just highlight the gaps, but highlight some of the strengths and the resilience of the community, which I think is something that we need to make sure we talk about as we have kind of a balanced conversation. So let me ask both of you, you know, we want to achieve health equity for our most vulnerable populations. How do we do that?
Would I be able to start? I think one of the things is, and I'm glad that we're having this conversation, is I think at first we have to really acknowledge that there are health equity issues. And, you know, some of our most vulnerable populations, including LGBTQ people, face health equities in terms of some things that are obvious, right? Not having access to quality healthcare, but also things that are not so obvious, like not having health insurance or the right health insurance, right, to get vital care that they need, whether it is a specialist or, you know, some sort of medication, you know, or not having access to those specialists that really understand their identity. I think collectively we often hear, you know, whether it's an academic or nonprofit, or even sometimes in the healthcare space, we hear a lot about disparities. But I think when you start talking about health equity, you have to start talking about solutions. And that's where we really begin to make progress in terms of, you know, not just the solutions, but how do we get there? So I think that's definitely a way to attain health equity. I think research and data to really understand and address those health disparities are necessary. And I think also finding solutions to ensure that healthcare is affordable to those populations. I think that is so crucial. We know from actually not Dignity 2024, but Dignity 2023, that, you know, people really have these strategies for cost savings when it comes to healthcare. So for example, with medications, sometimes people are skipping their doses or cutting their pills in half, or not picking up their prescription, or not taking it as they should. And so that's really an issue in terms of the economics of health equity. And then in dignities, my last point, in dignity, there were a number of people who said that they didn't go seek seek medical attention when they needed it. And the one reason was because of affordability. You know, it was too expensive. And so I think in order for us to attain health equity, we have to begin to address some of those things.
That's a great way to start us off. Earline, thoughts on how we can actually attain health equity for our most vulnerable populations?
So I guess I would say that I totally agree with everything that Cassandra has just said. And one of the things that came to mind while Cassandra was speaking was the need to make sure that we are educating providers on how to work with individuals with that are self-identified as LGBTQ people. And specifically, you know, from a standpoint, I speak of the trans population. There are so many people that really need to understand us and how to work with us. And when it comes to pronouns, languages, and all of that, because even though, as you can see, you know, my presentation is female, I cannot tell you how many times I find myself saying, it's ma'am, it's she, it's her. And a lot of folks are not as settled as I am in terms of accepting that they will walk away. And I think that's what's important, trying to make sure that we don't have folks that will walk away from services, especially health services, like Cassandra was talking about. So, you know, educating the community is really important, but also educating providers and remembering that that person that's on the front line that's asking the questions is the one that really needs to know how to, if you're not clear, then just ask and say, excuse me, how do you identify? You know, what pronouns do you use? It's not hard to do that, but some people have those inner issues with discrimination within themselves, and I run into it all the time. And I mean, I have some people say, well, I say it, I didn't mean it that way, but they never apologize for misgendering individuals. So again, I'm piggybacking off of Cassandra. Thank you, Cassandra. You covered pretty much everything, but that one thing I really wanted to make sure I impress and put out there to folks to make sure that they're making sure that organizations are sensitive, have information for the LGBT community. Thank you.
I agree with you. Can I jump in real quick,
course.
Cassandra? So to your point, I totally agree with you. One of the things that we did for our Dignity series this go round is we also did some focus groups. And one of the things that that we heard from our respondents was that sometimes it's not the healthcare provider.
Mhm.
It's their first point of contact, their entry point into the healthcare system.
Yeah.
And so everybody that they come into contact with before they sit in that seat to wait for their doctor, you know, has the potential either to welcome them in or to push them away. And so you're absolutely right, Earline. That's a great point.
Yep, I'm an anesthesiologist. By the time I meet a patient for the first time, they're usually about literally 13 other members of the healthcare system that patient has interacted with, from the scheduler to the front desk person to the valet parking person to the nurse. You know, there's a lot of folks. So that point's really well taken. I will just chime in too that to get to health equity, we have to have a deeper understanding of where the gaps are. And in my mind, you know, I'm a scientist, I'm a physician. It starts with the data, and we just for decades have not had good data on what's happening to the community, and that's why this dignity report is so important. It's another piece in the puzzle in understanding what's going on. We still don't collect at the federal level through census information, through reports, through Health and Human Services, through the FDA, through CMS, through other agencies, the kind of demographic data about sexual orientation, gender identity that we need to. That is a gap. I will confess that the AMA, we only relatively recently started collecting data on our members about sexual orientation, gender identity, so we know what the workforce looks like, right? As we're trying to understand, you know, who's coming into the workforce and diversity issues, that's a really important component. So there's a lot to be done on the data collection front, and obviously it ties into what the Dignity Report is all about. Let me go to my next question, and just so folks know, I've got some prepared questions that we'll work through for a little bit, and then I know we're getting a ton of audience questions. We'll get to as many as we can, but we'll turn to those in just a little bit. Let me ask both of you, how do intersectional identities create health disparities, and how do we address those intersectional disparities?
I think we've touched on it just a little bit, but I think understanding that the communities are very diverse and that not all LGBTQ plus people experience healthcare the same, nor do they all have the same healthcare needs. I think that's very imperative. I think something that you mentioned, Jesse, a minute ago, is even when we're collecting data, is being able to disaggregate that data, so that way you could take a look at, you know, people who are just bisexual, people who are just transgender, or people who have those multiple intersections. And, you know, that's something that we tried to do with Dignity 2024. Is really to look at those experiences and do those oversamples and do some analysis to ensure that we could see the fuller picture of what's happening. You know, one of the things that I found interesting in Dignity 2024 was that there was a majority of people that rated their health as excellent, very good, or good. However, there was such a large percentage, 85%, that said that they were taking at least one medication, and 45% that said they had a disability, chronic illness, or both. And within that, 47% said that their disability or chronic illness actually helped them, hindered them from fully participating in work and household and other activities. And I think when we talk about intersectional identity, oftentimes we talk about it from the lens of race and ethnicity, but we forget it's so much larger, right? We forget to have that conversation about even professionals, right? We forget to have the conversation about what does it look like to have a disability and be part of the LGBTQ plus community, or what does it look like to be over 50 or 65, and also be part of the community. And then the other thing is, again, tied to that diversity. One of the things that, you know, stood out for us in the Dignity Report was, in terms of intersectionality, was that bisexual, pansexual people and those who are transgender and non-binary, actually their health experience looked different than those who are lesbian or gay. So there were greater health disparities in terms of mental and physical health. You know, there was this compounded discrimination. And so I think understanding that will help us to create better solutions and strategies and outreach and advocacy. So I'm going to pause there and give Earline a chance to jump in.
Well, thank you again for allowing me to speak. And you know, when we start thinking about intersexual identities, I often am drawn to this, thinking about where we are now in 2024, that how diverse is the word, how diverse the LGBT community, specifically now, myself witnessing the transgender community, because for the first time in my life, I'm actually seeing more and more transgenders that are attracted to trans men, and then also transgender women who are consider themselves as lesbians and are attracted to women who are what we call dom. And so it's a real cross in terms of what's going on within our communities. And I'm oftentimes asking, like, wow, you know, so what does it mean to you to be in such a relationship? When I ask the question of what is it that is the driving force behind this whole intersexual identity thing that's going on, and many of them just say that men are not treating them the way they want to be treated, and they find themselves in these other relationships. So, you know, again, from a harm reduction standpoint, we receive people as they are. We're not here to criticize or try to change folks. But at the end of the day, you know, it is what it is. That's our community. And, you know, who am I other than just to be there to counsel and support people in terms of where they're at?
And I was going to also mention, I think in terms of intersectionality, I think those disparities sometimes are widened given the history and the experience people have had. So when you think about people with disabilities, sometimes there are some challenges with access to healthcare, access to care, and so it may make them shy away from going to the doctor. You know, we talked about indignity. We saw that there was a percentage of people that said that they didn't go to the doctor when they really needed it. And you think about maybe some discrimination during, you know, the height of the AIDS epidemic, especially for older LGBTQ plus, that may, you know, deter them from going to the doctor unless it's absolutely necessary. And Jesse, as you know, the longer you wait to go to the doctor, the worse it's going to be. And, you know, sometimes by the time people get to the doctor, it's, you know, they're really, really in a dire situation. And so I think that's why intersectionality has to be a part of the conversation. And it's so important in the strategies that are put in place by our healthcare providers and policy people and people that make the decisions.
So that brings me to the next question that I wanted to ask, which is how do we, with that as background, create more inclusive healthcare environments that are aware and responsive to those needs across different identities? I have lots of thoughts, but I'll jump in at the end. I'll let you guys get started.
Well, I mean, I guess, again, going back to, I think what I said early on is, first and foremost, you need to make sure that agencies are competent and able, you know, trained to work with LGBT individuals. And this is not just, again, for the trans community first, but just the LGBT community in itself, because I'm sure there are times that we don't know in terms of how people identify. And, you know, some people I'm learning more and more in the group I had today. Some of the ladies were saying they did not want to be stigmatized with being labeled. They didn't want to be called transgender women. They just wanted to be acknowledged as women. And again, like I said, the healthcare system, housing, all of that, there are flaws. And I think that Van Michael said it best in a comment just now that was posted, and I saw it, and where he said HIV and transmasculine is something that we need to put first and foremost out there.
Yeah, and I'll say, in terms of creating more inclusive healthcare environments, I think language matters. And we talked about ensuring that, everybody in the healthcare system, like you said, Jesse, from, the parking attendant to the doctor, to the clerk checking out, is using common acceptable language. I think increased access to healthcare, targeting transgender, non-binary, bisexual individuals. I think, having more mental health resources, telehealth options. We know from Dignity 2020 that, so many people were using telehealth, of course, during COVID, but many transgender people continue to use telehealth options post COVID because, of course, they don't have to deal with the stigma or all of their anxiety. All the anxieties are kind of eased. I think, better coordination of care between regular providers and specialists. I think promoting, running campaigns to promote the importance of creating a relationship with a regular provider and to get the necessary preventative care. I think, Jesse, you and I have talked about this before, giving healthcare providers tools and training, so that they have these competencies and these sensitivities. Let me see what else. I think, and then we talked about also research, right? Just to better understand what's really happening and to be able to disaggregate the community so we get a better view and understanding of what's really happening, with these individuals. So I think these are just ways, just a couple of ways that you could start to create these inclusive environments.
I'll just add in, we have to make sure that our exam rooms are safe places psychologically for everyone. And for too long in too many places, that just has not been the case. And we need to make sure that people are able to share who they are, who they're loved by, who they love, who their family is, their chosen family, their biological family, their family by law or legal or whatever it is, so that we can understand how we can help them through their healthcare journey. And there are a lot of ways that the AMA is obviously trying to do that through education and policy. And I don't want to derail the conversation, but I think those things really at the heart of how we create inclusive healthcare environments. So I just mentioned chosen family, but what is the role of chosen family from your perspective, Cassandra, Earline, the role of chosen family in creating health equity for LGBTQ plus seniors?
I mean, I think, Rupert said it in his video where he said that, I believe his partner's name was Scott, was his advocate. And because so often we're estranged from family, and we have, not strong support systems, our chosen family becomes our advocates. They become our caregivers. The study, Dignity 24 noted that, about 6 in 10 respondents said that they had either previously or currently providing caregiving. And so we know as a caregiver, there's so many hats that we take on, whether it is, the advocate at the doctor's office, just taking somebody to medical care. And so So I think that advocate piece is a big part of, for the chosen family, especially when the situation is dire. I think it's a little tricky because I think for healthcare providers, you guys also have to ensure that, you're respectful to this chosen family, but you're also protecting the privacy and the wishes of that care recipient. And so, yeah, so I think that's really the heart of it.
And in my community, in the community that I'm a part of, chosen family is very key and important, because what I find many times is, and just today we were having that discussion in our group about estrangement from family. So when there's estrangement from family, because family are, in a position where they resist and do not accept who you are in terms of being your authentic self, then you do reach out to the community. And we form this whole thing that we call the extended family, meaning that we have godmothers, or like I have a godmother named Jerry Hughes. She's an older woman, and I just love her to death. My mom has passed on, but the fact is, she is in my life. And when I get sick or something, and I'm in the hospital, and I tell the doctor my mother's coming, this older, elderly white woman who's esteemed in the community, works at DOES and all that, she comes, and heavily bass voice, but she's transsexual female. And I say, here's my mother. You can share. And the doctor said, are you sure? This is your mother? You want me to share information? And I said, yes, that's my mother. And she said, this is my daughter. And so that whole thing, that's my personal, but we talked about that today. And a lot of the folks in the group were talking about going back to 13 and 14 years old, and how the father, or be it the mother or someone, was resistant of them being who they were to be themselves. And again, remembering that years ago, 20, 30 years ago, we didn't have the word transgender. We were simply gay. And I can tell you that my godfather, and when I say his name, you are going to be shocked, I call him Dr. Frank Kameny. Him and Scott Levy came into my life at an early age when I was put out the house at 14. And they had the Gay Men's Alliance on 17th Street Northwest. And they took me in, put me in a hotel room. These were gay men that did all of this. And I loved Dr. Kameny, and all the way up until when he died, I was actually in charge of helping to put together his service and all that down at the Carnegie Library. So that's many years ago, but I say that to say the estrangement from family is very big in our community, and it is so important that we acknowledge there is such a thing as chosen family, because a lot of times we can't go to our family members who are actually our biological family members. So thank you for allowing me to share that information.
That's wonderful. So let me ask one more question, and then we'll get to some of the audience questions. You've got the immediate past president of the American Medical Association here. How can physicians, as well as other healthcare professionals, better care for LGBTQ plus seniors? And I'll give two quick examples of things that I do every time with all my patients. One is, and I'm an anesthesiologist, I meet people when they come in for surgery. I always ask who's in the room, right? Because I meet all sorts of chosen family and friends and lovers and all sorts of things, and I never assume who it is. I ask who they are, and I thank them, and I say thank you for being here. It's so important to my patient's journey, that you're here to help support them, and it means a lot. And I know that it's difficult for a lot of those chosen family members to show up because they may have had bad experiences not being welcomed in a healthcare setting in the past. So I always make a point of thanking folks for being there. The other thing that I've started doing more recently is when I have a patient on PrEP, and there are a lot of LGBTQ plus seniors on PrEP, which is a wonderful HIV prevention tool, because there are a lot of LGBT plus seniors having sex out there who benefit from PrEP. So let's applaud that, right? And not stigmatize it. And I look, taking a pill every day, and some people are on the every other month shots or whatever, but But taking a pill twice a day is hard, and I say, congratulations for doing this, for showing up, for getting your testing done, for taking control of something that you can manage. And that's something that every time I find somebody on PrEP, I congratulate them for doing that and taking ownership to try to remove some of the stigma that's still out there. So other ideas, thoughts, Cassandra, Earline, on how physicians, other healthcare professionals can better care for our LGBTQ plus seniors?
Sure. I was going to say it's interesting that you talked about seniors, senior LGBTQ folks having sex, because we have some relationship questions and sexual health questions in Dignity 2024, also including, are you taking PrEP? So I think that there's some practical things that providers can do that can signal safety as soon as somebody walks into an office, whether it is having the rainbow flag prominently placed or having a staff members wear rainbow ally pins, making sure that the forms have inclusive language. I think these are really, really simple things, or having even pictures of same gender couples together. I think those are such key things, and they're simple things. But as soon as I walk into a doctor's office, if I see any of those things, I'm like, oh, okay, these people understand me. So I will stop right there. But yeah, I think those are just like simple little things that can help.
Perfect.
And I guess I was thinking about the question, and the first thing came to mind is how to make your office spaces, organizations more sensitive with information sharing that's on the LGBT community. And I raise that because a lot of times, especially sometimes the medical providers, there's not information on like working with the trans folks, and having that literature and information might make it a little bit easier and comfortable for the person that's coming in for services. Because for me, now that I'm 66, in the past years, when I used to go in office like Whitman Walker and other places, and the first thing I look for is trying to see, well, do they have any brochures or any information on the community that I'm a part of? And I know that there have been some private organizations that I've gone to, and they have absolutely nothing.
Yeah.
Everything is pretty much language only, but nothing like pamphlets, brochures, and information like that. And I think that that's something that we could still, even today in 2024, we can ask in organizations and the directors to try to figure out how to have more sensitive information. And as you said, also have some safe spaces where we can meet, congregate, and discuss what some of our issues are. Thank you.
So we've got lots of questions. We'll get to a couple, and I know we're going to run short of time, but let me just throw out the first. I appreciate the person who put this in there. You've been very patient because this came early in the conversation day. But the question is about conservatorship. And there are a lot of abuses out there, a lot of challenges for those seniors. How can we achieve health equity for those in conservatorship? Any thoughts?
Ooh, that's a tough question. I would say AARP absolutely has resources. We have a legal counsel for the elderly, and that may be, a first point of entry to really, help support.
All right, let me just rapid fire go through a couple more. How has the identification of challenges in the report or past reports impacted advocacy work at AARP or the AMA? And I can certainly talk about the AMA's work, but I know, Cassandra, if you want to give any perspective on.
Sure.
What this is doing.
Yeah, so AARP has definitely, again, we started this research on LGBTQ folks, back in 2016. And since then, AARP has filed a number of amicus briefs in support of LGBTQ rights. So everything from an amicus brief against the Social Security Administration for denial of spousal benefits. And this work has informed that. AARP has, publicly endorsed the Equality Act based on data, based on the research that we found. And so it definitely impacts our policy and advocacy. We have 53 state offices. I'm trying to be mindful of time. We have 53 state offices. A majority are working on LGBTQ outreach and advocacy. And so we're always trying to be at the forefront to make sure that we are supporting all people that are 50 and older.
All right, this next question, which may be one of our last, let me ask to both of you. How should organizations who are engaging with older adults work to support those who are socially isolated, but they're active online? Earline, do you have thoughts on that one?
Well, let me just say, many of the individuals that I work with that are of the senior population are not online. So that's first and foremost. But I think that organizations like AARP do a remarkable job. I've seen how they put information up and how they have groups and other things for the senior LGBT population. But again, I always say I want folks not to assume that everyone is online, because everybody's not online. But again, I think the resources, the information that AARP puts up to support our community is phenomenal, and it's information that's needed.
All right, thanks.
And I think for AARP, again, we have 53 state offices. We are very, very concerned about social isolation. We know that social isolation has the negative mental and physical health outcomes as smoking 15 cigarettes a day. It used to be 14, now it's 15. And so we take that very seriously. The state offices work to create communities to support our LGBTQ seniors, but also we also partner with other organizations, community organizations, to help combat some of that loneliness and social isolation.
That's great. All right, so we need to end on a positive note. This has been a great conversation. I want to ask you both, despite all these challenges, we've made a lot of progress, right, in recent years. Could you each speak to some of the progress that you've seen throughout your lives?
Well, me personally, I've seen over the years, and of course, again, being a part of the senior population, that more data is being collected. And I think that has been key. Is first and foremost in what we, looking to do, like the DC Department of Health here in DC and Department of Behavioral Health. So everybody is now kind of looking at how can we do surveys, focus groups, and gather more information on the LGBT community, but specifically the trans community, because CDC in the past has not done the best job in terms of getting information on our community. And if we don't have information, then they can't allocate funds. So I've learned that over the years. And so I'm a staunch advocate of making sure that folks are gathering data, even if it's just simple support groups within your agency, keeping notes and information on how you're doing that. Thank you.
Indeed. I will say, I am encouraged that 84% of our participants said that they have a healthcare provider that they trust, right? I think people are more willing to, talk to their doctors openly, share their identity. And I think progress is, my God, the AMA had its first gay president, Dr. Jesse. That's progress.
It is amazing. And I'll tell you, I've shared previously the very moving experience that I had this past year of being able to donate blood for the first time as a gay man, something that has been banned for decades because of bias and stigma and outdated policy scientifically that finally, because of the work of so many, was reversed and rectified. And that was a personal highlight of my year as AMA president, to be able to go and make a donation with my husband, Judd. And obviously we've got a lot of work to do, but we need to pause and celebrate the victories as well. So I think we're out of time. I just want to thank you both, Earline, Cassandra, for this important conversation. I want to thank everybody who tuned in, and I want to thank Outwards for your support, as well as AARP for taking on this critically important set of issues. Thanks, everybody.